Good afternoon. As you know, I'm Giuliani. I work for the National Institutes of Health. However, I'm going to be presenting ECD and the brain on behalf of Dr. Eli Diamond from Sloan Kettering. And I'll try to do my best to explain neurological issues with Graham-Chester disease, since I'm not trained as a neurologist. However, we do have the experience of seeing patients with these disorders, so I'll try to do my best to answer your questions. So we will start first to discussing ECD lesions in the brain and the spine. There are other areas of the central nervous system, such as the pituitary gland, the brainstem, and other specific areas that also can be affected, but overall, the brain and the spine is going to be our focus. You can have neurological problems without ECD lesions. There are some patients that have normal MRIs and still they have deficits in their neurological exams. We're going to discuss a little bit about thinking and memory problems associated with the disease and other issues that are less common and what you can do in order to issues. At least 1/3 of the patients with ECD have problems in the brain. And when we say brain, it can be any part of the brain actually. It doesn't have to be the most common areas affected. And this is not including the spinal cord, which is another area that we have been evaluating recently, and we have discovered that there are problems there as well. The most common symptoms are balance problems, which means difficulty walking and difficulty standing. You're kind of wobbly, or you're walking like if you had been drinking a lot of alcohol. Speech problems, which is that you cannot enunciate or pronunciate words correctly, even though you know. Some people lose this quality. Coordination of arms and legs, which you might try to tell your legs or send a message from the brain saying that you want to walk, but it's difficult for you to do that. Also, some patients, in terms of the coordination in their arms and hands, their signature and their writing changes significantly, as well as the ability of them of tying their shoes, for example, or holding a cup in order to have some coffee or some tea. More severe symptoms include trouble swallowing and unusual or inappropriate emotions like laughing when it's not appropriate, as well as crying because of any news that's given. These are the most common symptoms, and they're related to specific areas or associated with specific areas of the brain that we call the cerebellum and the brainstem. These are examples of lesions in Graham-Chester disease in the brain, and as you can see, if I can you see the mouse there? No, I can't. But the areas that are lighter, or pale, light, those are the areas that are affected, specifically in the center. You see there's this, just want to, that's an example of a lesion in the brainstem, and they can manifest in patients in different ways, and that's because of that area of the brainstem, what is it's doing, what is its function, what is the nerves that are located there, and then that translates to the deficit that the patients have. Some patients have horrible MRIs that are really bad and they don't have any symptoms, so that's another thing that we don't understand. Another can have a really small lesion and be really impaired and have a lot of disability associated to that lesion. These are other examples of tumors in the cerebellum. And other symptoms associated with ECD and central nervous system health are dementia, which is when patients have problems with memory. That is an area of active research right now in the community, because we really don't understand why people have what we call neurocognitive decline. They have memory problems. Some patients have memory problems, and we might have a theory why they're having it. Others, we simply do not know why. So that is something that is really an interesting area of research right now. Incontinence is also associated more when you have problems with the spinal cord, which is something that, as you have been talking, you can have issues with your bladder, or you can have issues with fecal incontinence, depending if the nerves of the spinal cord are affected. You can have issues with hormones, specifically diabetes insipidus, and this is because the pituitary gland, which is located really close to, but it's located in the central nervous system, is the gland that is in charge of producing what we call the messenger for the endocrine glands to produce hormones. So the most common problem is diabetes insipidus, but you can also have issues with gonadotropin hormones, which are the sex hormones, and you can have issues with the endogenous production of cortisol, for example. Mood and behavior problems can be associated with having disease in the brain, as well as depression and fatigue. And these are underestimated and not acted upon. And it's something that can be really treated easily. And even though we don't understand exactly why this is happening in the patients, there are things that can be done in order to improve the quality of life of the patient. These are further example of other lesions in the brain. But one other interesting thing about this is that even though we know that that's ECD, some patients might have disease just in the brain, and they can be misdiagnosed because the disease mimics other disorders that affect the central nervous system, such as multiple sclerosis and a lot of parasitic infections that go to the brain. Also, other types of cancer, like lymphoma of the brain, can present like this, but it is important to have a good neuroradiologist to read these images, and if they don't know about ECD, they need to be educated about it, because there's some lesions that can be missed. And because it's not the routine areas of the brain that are affected, and people sometimes don't report what they see in those areas. ECD in the brain and its treatment. So the disease in the brain is probably the most difficult form of ECD to treat, and that's because the brain has its own protection. The human body has been created to protect basically the brain of any injury or any chemicals or any substances. So there is a thing that we call the blood-brain barrier, and that prevents many things to go into the brain and affect the brain, and that includes medications. So there are many drugs that we have been using in the past for Ehrlich-Chester disease that do not pass the blood-brain barrier. However, with all the new therapies that we have, the targeted therapy that we've been discussing today, we know that these drugs can go into the brain. There are other options that can be used if you don't have the mutation, as you can see here. You can use interferon chemotherapies and other immune drugs that can go to the through the blood-brain barrier, but it's really important to see whether you carry one of these new gene mutations in your affected tissue, so you can be treated either with a BRAF inhibitor or a MEK inhibitor. This is an example of successful treatment of a patient that did not have the mutation and was treated with systemic or non-target therapy. As you can see, the lesions around the meninges disappear completely. And this is not my patient, so I cannot say exactly what happened. Clinically speaking, how was the improvement? But it's an example of that even though they're difficult to treat, there are options. You just need to look for someone that it will be willing to go to that extra mile in order to treat such a challenging disease. Ehrlich-Chester disease affecting the spinal cord, it is not very common, it's not very well presented in the literature. However, there hasn't been that much research for it, and now we're learning a lot that the spinal cord needs to be assessed and evaluated in patients with Ehrlich-Chester disease. You can have a normal spinal cord in an MRI, but if the bones around the spine are affected, this can lead to problems with the nerves, and then each area of the spinal cord releases or gives origin to a specific nerve. So the organ or the area that nerve is supposed to be controlling is going to be affected. And most commonly, we see patients are complaining of bladder incontinence or issues when they're urinating, or they have specific or unspecific signs like pain and spasms of the muscles around the back. That also comes with back pain, which is really debilitating for the patients. And we haven't seen tumors growing that commonly, but we see changes in terms of volume loss of the spine, and also abnormal signaling in MRIs that can be translated to something inflammatory or some process going on there that we cannot determine easily, but most likely related to the disease. You can also present with neurological deficits, most commonly with issues with balance and gait, without having tumors. But we don't know exactly why this is happening. However, And you can see in these images, we've seen that patients either have volume loss secondary to the disease, and that can translate clinically to having problems with your balance, with your memory, with your speech, and other of your motor functions. But we also noticed in PET scans that, which is the area where that's circled, that there is decreased metabolism or hypometabolism in certain areas of the central nervous system. And what that means is that the activity, the amount of energy, the work that the organ is supposed to be doing is diminished. We don't know exactly why is that. It could be because of the disease, because of a secondary insult, because of old inflammation. Some pathways that provide energy to the brain might be inhibited because of the disease. That is something that we need to be smarter about, and currently there are some research projects underway in order to understand why this is happening and how we can treat it. Cognition is something that is really important to assessing patients with Erhard-Chester disease, and the name exactly, we're calling it neurodegeneration or just neurocognitive decline, but it's something similar to what patients with Alzheimer's, Parkinson's, and diseases like that can present with. It's very common, and it's not properly addressed or treated because there's not that much out there that can be done actually. Patients complain of trouble paying attention, trouble remembering things, multitasking. Some patients need to stop doing their work because they can no longer concentrate or give the same performance they used to give before they had the disease. And this also happens with patients that are told that they don't have ECD in the brain because the MRI is negative. And again, we really do not know why this is happening, but we have ideas. Specifically, since Eli Diamond is a neurologist, they are doing specific research for that in Sloan Kettering. And this is an example of one of those scans that he does at Sloan Kettering. And one of his focus is trying to understand why there is loss of volume in the mass, why the brain is shrinking, and they're using this at Sloan Kettering. So that's, if you have any problems with this, or your neurologist has told you that you have issues with the volume of your brain, it will be important and good for you to contact Eli Diamond and have a conversation with him about that. And basically the cortical thickness, the cortex, is one of the areas of the brain where we have a lot of the cells that give the information or sends the messages to the different parts of the body in order to have some function or do some motor activity. And that's a focus of his research. Other neurological problems that we can see in ECD are neuropathy, which can be, most commonly, it's numbness and burning sensations in the feet, and that can give a lot of either pain and disability to the patient, as well as problems with balance, because you cannot walk very well, since every time you walk, your feet are hurting. So you need to have also good communication between the nerves in your feet and the nerves up in your brain, and that communication is disrupted, and you can have issues with balance as well. That can be also presented with severe pain. And as you heard, probably the pain associated with ECD can be really challenging to treat, whether it's the pain associated with the bone or the pain or pain that's associated with some nerve damage. The medications to treat both types of pain are different, and some patients do not respond to this, and they need to address it with different modalities. For example, some patients at the NIH have had good effect using acupuncture, and also techniques like Reiki and other more alternative kind of management. The pains and also the neuropathy, there are more common causes for it, for example, diabetes, but also hormone deficiency as well as nutritional deficiencies can cause this. And one thing that we have not discussed is that many patients with ECD have low levels of vitamin B12 and thiamine, which are really important for central nervous system health and proper function. Even though the pain is challenging, it can be treated, and every patient that has ECD and has pain needs to see how this pain can be treated, because it's really debilitating. What can you do as a patient? even though this is challenging for us as doctors to treat, you need to be greedy with their quality of life. This is one of the things that you can actually be selfish without feeling sorry. The way you feel is the way that you're going to be able to interact with your environment and with your loved ones. So just try to do anything you can to actually feel better. Sometimes we are giving the patients medications like dabrafenib and verapamil, which might make their quality of life good in a sense, but also with all the side effects, it might make their quality of life not that great. All ECD patients should have at least a brain MRI, and then other MRIs as needed depending on how their neurological exam is, and that will be determined by your ECD treating physician or evaluator. You should have an evaluation for neuropathy, which is really easy to perform. It's a really standard test. It can be done by a general practitioner, by a neurologist, or even if you have diabetes, the endocrinologist can do it for you. You need to treat your fatigue. There are many good medications to boost up your energy levels, and also exercise. In my experience, when I was seeing patients that had issues with balance and they were tired, many doctors told them not to do exercise because of the risk of falling. However, we've noticed and we've seen that exercise improves even the balance of some patients. Physical therapy, occupational therapy, all these things improve their quality of life. You need to keep your body in movement, in motion, or then the body will just give up in a sense. So you need to keep yourself active even though you feel that you're tired. You need to treat depression and get vitamins and your hormones checked. If you have unexplained symptoms, you need to get in contact with an ECD specialist. If there is not an ECD specialist in your city, go to the Global Alliance website and send an email to any of the doctors in one of the referral centers, and they will be happy to discuss any of your symptoms and get in contact with your doctor. Another thing is that we have been talking about what the disease does, but also a patient that has ECD probably has other issues like high cholesterol, hypertension, and other primary things that are not associated with their Winchester, and they might be taking medications for that. So when you see things that don't make sense, also look at your medication list, because maybe you might be taking drugs that are having interactions one with the other, or you might be taking the medications that might increase specific symptoms. For example, we treat the patient for depression, but there are a lot of drugs for depression that produce cognitive decline and memory problems. And also the long-term therapy of certain medications that we're using for ECD can be associated with cognitive decline. So it's always good to start with your medication list and see if none of these medications are responsible for your signs and symptoms, and if they are, how can they be modified to give you another medication that is not as bad or has that much side effects. And check your vitamin levels and hormones, because those are really straightforward to treat. You just need to have supplementation, and many things can be improved just by those simple steps. I'm gonna leave it as that, and if you have any questions for me, I'll be happy to try to answer them. Thank you.
Thank you. Are there any? We have one question back there.
Oui, merci. Tout à l'heure, je suis intervenu concernant la prise en charge de médicaments qui n'étaient pas remboursés par la sécurité sociale. Mais maintenant, je voudrais vous poser la question des effets secondaires. Moi, j'ai été à l'interféron pendant 4 ans, 5 ans, et je suis maintenant aux Elvoraf depuis 3 mois. J'ai un souci, je pense pas que je sois le seul. Alors, en tous les cas, déjà, je voudrais vous féliciter, docteur, et féliciter aussi les gens qui vous traduisent, parce que déjà, je ne sais pas comment les uns et les autres vous comprenez ce langage médical, mais je vous avoue, c'est quand même particulier pour nous qui ne sommes pas dans le milieu. Donc, j'aimerais que si ce soit dit, parce que je félicite donc toutes les interprètes. Donc au-delà de ça, je voulais vous dire, je suis maintenant aux Elboraf, et comme j'étais à l'interféron, c'est exactement la même chose. Je suis fatigué, j'ai envie de faire plein de choses, mais je n'avance pas. Je suis un très grand bricoleur, après avoir été un politique pendant des années. Je suis un très grand bricoleur, et je sais pas, les jambes ne suivent pas la tête. En tous les cas, j'ai un souci de ce côté-là. Et j'ai aussi, et je ne pense pas être le seul, j'ai un souci de libido. Alors, est-ce que vous dites qu'il y a toujours quelque chose qui peut s'adapter ou se compléter par rapport à un traitement? Est-ce que vous avez connu ces cas-là et est-ce que vous avez aujourd'hui un moyen de traitement ou d'amélioration qui pourrait me convenir en tous les cas? Merci beaucoup.
You understand everything? Okay, you speak French. Okay, so first of all, the translation is, I'm going to be a little bit short, but the translation is excellent because this patient was saying he was understanding very well, and so he wants to congratulate everyone for the translation. So he's been for 3 or 4 years on the interferon. Now he's since 3 months on the Zelboraf, and he still remains very much tired, and so he wanted to know if there was something to do about it. He has also a problem with the libido, and so if I can say something, that perhaps some of the questions might be addressed this afternoon as well to Dr. Courtillo, who will be presenting on the endocrine manifestations. But anyway, he remains tired despite the fact he's off interferon and he's on Zelboraf, and he used to be very active as a politician, and now he wants to do some work at home, and he cannot because he's tired. So comment on this, please.
So if I would encourage you to have this conversation with your physician and try to see whether your vitamin B12 level has been checked. Patients that have fatigue, they will be doing better if they have their vitamin B12 level above 400 pg per ml. Maybe it's nothing that you should know, but vitamin B12 supplementation improves the fatigue levels, as well as vitamin D. Many patients need, or not patients, but people need to have normal levels of vitamin D to have proper energy levels as well. In terms of your libido and things like that, was your testosterone level checked? And if it was checked to see whether your total testosterone and your free testosterone are within normal limits in the supplementation. The supplementation of testosterone is really straightforward nowadays. And all these things that I'm saying that might be deficient are probably associated with the disease and the inflammation secondary to the disease. And once you have decreased testosterone, men get fatigued, they get irritated, they get angry really easy, their mood changes, and they also get muscle weakness and fatigue. So we need to supplement with testosterone if, in that case, it hasn't. If none of these things are abnormal, I will see if you can encourage or ask for you to be seen by a physical therapist that can do an exercise routine for you in order to strengthen your core and also have more functionality in or get your fatigue under control. Another thing that just came up to me, if you are being treated with steroids, what dose of steroids you're taking and for how long you've been taking this steroids, because also as a side effect, it's really rare, but you can have what is called steroid-induced myositis that can produce a lot of fatigue. So there are many things that can be checked and see if they're straightforward and help with that.
Thank you. You did a wonderful substitution job. Yes. All right. Thank you. Okay.